we're using mostly for emergency situations, for cold situations, elective cases. We are rarely using plain films anyway. So it's going to be a short talk, which you'll be pleased about. As I said, we're replacing it with CT and MRI, and it's a very practical talk. So plain films are no longer used for ear assessment. Temporal bone CT has replaced plain films completely, and you've got a talk on temporal, or you've had a talk on temporal bone CT already. So that it is more, we're doing a lot of temporal bone CT. When I joined, I think we were doing hardly any, and I developed the service here with the ENT surgeons regarding mastoid CTs, and we are using it for surgical planning. They understand what we can tell and what we can't tell, but they also look at it as a surgical map. Plain films are no longer used for nose assessment, as I said, as well. We can't differentiate between, we largely can't differentiate between an old fracture with fibrous union and also from vascular markings. So it is a clinical diagnosis and a clinical management. Paranasal sinuses, again, has been replaced with CT, but here I can show you some anatomy. That's your frontal sinus, your ethmoids are on either side, and that's your maxillary antrum, and you can see that left maxillary antrum is opacified. We can use it for assessment of salivary gland calculi, and here you've got one, but we are also using CTs and MRIs for salivary gland calculus to find out the length of the duct, edema within the duct, and that kind of thing. So this is a lateral view of the salivary gland calculus, and here you can also use an intraoral view to see the duct calculus. So here, we can also, as I said, CT and MRI is emerging, and we can see the same calculus. It's got the density of bone. You can see it along the line of the left submandibular duct. MRI, you see it as a filling defect, a salivary gland calculus. So again, cross-sectional imaging is actually replacing. Overall, as you look at trends, amount of plain films we're doing is reducing because a lot of chest and abdominal work is also replaced with CT. In ENT also, we're replacing a lot of our work with CT and MRI. But they continue to be used for detection of fracture of the facial bones and mandible, and you've seen these slides before. There is a fracture of the zygomatic arch there that I showed you previously, and there is a fracture of the left mandibular condyle. It's difficult to point it out there. It's very subtle. I can't see the image very well, but so fractures is one. Again, we're using it for plain X-ray. We're using it for foreign body of the throat that we discussed earlier, and here is the retropharyngeal abscess that I talked about in my previous talk, and that's your coin foreign body in the throat, and this is the same foreign body that you've seen previously. And your bronchial foreign body, the dental amalgam, and as I said, we're using CT a lot more. Another plain film that I report still for some of the ENT surgeons is for adenoidal hypertrophy. And I think it's mainly, so here you can see the adenoidal hypertrophy, and that is your nasal pharyngeal airway. And what the main purpose, I think, is that you're looking for how is the nasopharyngeal airway compromised. So here you can see a sliver of the airway, and if we go back, you can see a more, the airway is more, it's got more space in there. So I think that is.
What is the request to get this view of the nasopharynx?
Post-nasal space.
Oh, do you specify then the power on it?
Power meaning?
So that to get that good quality of soft tissue, or you just mentioned soft tissue?
The quality will depend on the radiographer and and how much of what X-ray parameters they use, and the quality of your machine as well. The newer you're talking about the quality of this, isn't it? This is from one of our machines, and if you have a newer machine, it'll give you better quality images. So I don't know what machines you're using, but this should be a standard quality where you see the soft tissue and you see the nasopharyngeal airway very well. But there's also one other aspect, is that when the children, you can't keep them very still, you can't keep them this is a really nice lateral position. And when the radiographers are imaging, they're looking whether the mandibles are superimposed on one another. They should be a single line. So this is slightly tilted, and the more oblique you get, you won't get that perfect view. So it can be difficult. But here you can see enlarged adenoids. I'm not suggesting that we use that for your adenoidal assessment, but you can see it on cross-sectional imaging. And this is, you can see a swollen epiglottis with epiglottitis. I think the diagnosis of epiglottitis is rare, and I think I'd be worried if we were messing around with plain X-rays rather than just managing the patient. I don't know. But chest X-rays, the commonest X-rays, the plain X-rays that I report for ENT surgeons is chest X-rays, really. So it's to look for metastasis. It can be used as a screening test for your T1, T2 tumors of the larynx. With the T3, T4 staging, we're already using CT or PET CT anyway. So it's really for the earliest, and you might pick up somebody who's got a lung tumor, lung mass, and then lots of metastasis there. And it's also used when your patients are on the wards. A lot of your requests for chest X-rays for line placements, NG tube placements, and infections. So that's what I'm seeing ENT requesting plain X-rays for. In summary, plain X-rays is used for fracture detection of face and mandible, foreign body for throat and bronchus, airways, adenoid and epiglottitis, and for the lung for metastasis, infection, aspiration, and tube placement. But as I've said before, you are and everybody is increasingly using cross-sectional imaging of CT and MRI as a replacement for plain X-rays. Thank you very much. Any questions?